This is Cate Swannell from the MJA. Our special guest today is Lieutenant Colonel Michael Reade, who is Professor of Military Surgery and Medicine at the University of Queensland. Welcome, Professor, and thanks for your time.
Thanks very much.
This is running in conjunction with our Anzac Day issue. So we wanted to talk a little bit about military medicine and the history of it and where the big innovations might be coming.
Mm-hmm.
Tell us a little bit about the chair of military medicine and why it was established and how.
So my chair was established in 2011 as a defence industry partnership between the University of Queensland and the Department of Defence.
Mm-hmm.
I suppose we'd seen the advances in academic military medicine that had been generated over the preceding, 10 years of conflict at that stage. Principally, I suppose, driven by the United States and the United Kingdom. And I think as it applied to hospital trauma medicine, we, in our Defence Force, identified a gap in our capability. And so, in a way, modelled on the very successful research enterprises that also combine with teaching and clinical governance in the US and the UK, my chair was established.
You've been in the Army Reserve for 20 odd years, is it?
Indeed. I joined the Army Reserve in 1989,
Nice.
and until taking this job in 2011 had been, I suppose, fairly typical of a lot of medical officers who joined as medical students. I'd been employed in all sorts of roles in primary care in defence, all the way through to deploying as a specialist anaesthetist and an intensivist on operations.
So medicine came first for you rather than the military?
In a sense, there was a bit of a mix. I joined the University Regiment when I was at university, so that involved general officer training rather than specialty medical training. And I qualified as a general service officer, and I served as a troop commander for 3 years before I graduated as a doctor. And then, having graduated as a doctor, I transferred to the medical corps and took on those medical appointments after that.
So you're a specialist intensive care and anaesthetist, I
Yes,
believe.
that's right.
Pretty good skills to have when you're in the middle of Kandahar, for example.
Yeah, I think that's right. Certainly the focus of what military medicine has had to deal with in the last 10, 12 years has been trauma medicine, and therefore anaesthesia and intensive care medicine are very much the centre of that. We have what we call a deployable surgical brick of practitioners who deploy together, and that includes a general and an orthopaedic surgeon, an anaesthetist, an intensivist, and more recently an emergency physician. So we'll generally aim to send those 5 clinicians as a single team, and then potentially multiples of those teams for larger hospitals. So yes, indeed, in the last 12 years, I guess trauma medicine, one of the components of my specialty, has been very topical. But I think we'd be silly to lose sight of the fact that the vast majority of our casualties in really almost every conflict that we've been involved in since the Great War have been medical, that is to say non-battle casualties.
Right.
And we're very mindful to not lose our capacity, particularly to deal with infectious diseases. So although that hasn't been a focus of the last 12 years, that's to say in Afghanistan and maybe in Iraq, it certainly was a focus of the sorts of casualties that we were dealing with in Timor, for example.
Yeah.
And my position, although my position as an academic within defence was only established in 2011, we've got many decades of experience in tropical medicine. And Professor Dennis Shanks at the Australian Army Malaria Research Institute heads a research and teaching and policy effort based also in Brisbane, focused on infectious diseases as they apply to the tropics. So yes, I guess the topical bit of military medicine is trauma, but there's another, in fact, many other components to it that I think we'd be silly to lose sight of.
I guess when we're talking about 100 years since Gallipolis, last year was also 100 years of the MJA, as it happens. Mm-hmm. And I did a lot of reading of the archives. And what was clear was that every time we were involved in a war, some great medical, surgical innovations came out of that. Is that still the way that war and emergency trauma situations like that generate the innovations? Or are the innovations now going back into helping in war situations?
Very much at the moment there's a two-way traffic in that sort of research and policy implementation. And I think probably that was always the case. Yes, there have been a few advances in some of the technical aspects of medicine and surgery that are probably very specific to the military. So, for example, Ambrose Paré developing a method of doing amputations that involved covering the stump with a flap rather than just performing a guillotine amputation. That technique was developed on soldiers who were having amputations, and you could argue that eventually that would have come to the minds of a surgeon, but its development was accelerated by conflict. But there's other more subtle examples. So the story of antibiotics is a great thing to talk about. So as a penicillin was, I suppose, one of the stimuli for the development of penicillin was the high rates of gas gangrene in the First World War without an effective therapy in the First World War. And then with the understanding of what penicillin actually was and how it could be extracted and purified and manufactured on a large scale, the very large-scale deployment of that as a prophylactic and a treatment option during the Second World War undoubtedly hastened the uptake of antibiotics within the general community. Right. But it's probably wrong to say that it wouldn't have happened had we not had a First and Second World War.
It tends to be an accelerant, though, by the sound of it.
Yeah, I think that's the way to characterise it. I think it's probably a bit intellectually dishonest and maybe not quite right to say that war is beneficial in all of these ways. I think war's probably not really beneficial in very many ways at all, as many of us who've looked at the people who really bear the brunt of it, the patients essentially. But yes, there's a stimulus in wartime to focus on particular niches of medicine that probably wouldn't have attracted that attention otherwise. And trauma's a great case in point. So trauma in our civilian community is the leading cause of death. People between 1 and 44 years of age, and yet the amount of money that's allocated by civilian funding agencies to research trauma-related questions is minuscule compared to cancer and heart disease and all the other things that are very worthy of funding. But if you look at it in terms of societal cost, both in terms of lives and of course, especially in terms of traumatic brain injury, in terms of the ongoing cost to individuals and society of looking after people with trauma, the military is one of the few institutions that brings a focus that's very heavily on trauma and latter years of traumatic brain injury that's really been lacking in a civilian environment to any great extent anyway.
Traumatic brain injury, is that on the increase in military situations? Is that a symptom of the kinds of conflicts we're involved in?
I think in conflicts up until now, we haven't had a means of quantifying mild traumatic brain injury in the way that we have now. And so I'm sure lots of people in the First World War were exposed to high levels of repetitive low-grade blast. And given what we know now, I'm quite sure that many of them developed a chronic traumatic encephalopathy in much the same way that people might be more familiar with the chronic traumatic encephalopathy in sports players from multiple low-grade concussions to the head. But in the First World War, there were bigger things to worry about. We lost more than 150,000 of 330,000 in the First World War wounded, and about 60,000 killed. There were other things to worry about at that stage. And that's not to dismiss the people who've been very severely physically wounded and killed in the current conflict, but I guess we've been able, through better resourcing and better community support really, to concentrate on the more subtle effects of exposure to battle. And certainly we have appreciated that exposure to mild concussive blast is a risk factor for mild traumatic brain injury. I don't think we yet understand the epidemiology of that, because I think we know from sport that it can take many years to be fully manifest. But we've at least appreciated that it's likely to be a problem, and therefore one to which active surveillance will give us a better idea of its extent.
I would imagine that the ADF is also an ideal database for epidemiological studies as well. You've got them all at your fingertips.
That's very true. Perhaps less so in an Australian population, but international studies of trauma patients are difficult, and everyone who works in this area knows that it can be quite difficult to follow trauma patients up. I'm very much generalising, and I'm speaking in a civilian rather than military context, but the sorts of people who are involved in trauma, generalising, are often the sorts of people who it's quite difficult to track down how they're going in 10, 20, 50 years' time. Whereas in a military population, for a host of reasons, following those people up is relatively easy. Admittedly with some concerns around privacy and so on. But while they're in the military, of course we have easy access to them. But the vast majority will qualify for Veterans Affairs assistance, and so we're able to follow them up through the DVA system. And that's true not only in Australia but in the United States. I mention the United States because although we've had 41 killed in Afghanistan and around 260 severely wounded, those figures are a tenth to 100 what's been the case in the United States. And so with their very much larger database, they have a database of around 50,000 very severely injured people from Iraq and Afghanistan, followed up through their Veterans Affairs system. With such statistical power, I think we're likely to get an insight onto many of these conditions that we've never previously had a chance to understand.
How's the medical corps held up in terms of their own experiences of Afghanistan and Iraq?
We I guess you'd say, I would say this, but I think we've done a good job. We haven't generated our own healthcare facility other than a primary care facility in Afghanistan or Iraq. In Iraq we did deploy primary care teams, but in Afghanistan, in addition to those primary healthcare teams and evacuation teams that we've had, we sent hospital specialists to work in the Dutch hospital in Tarin Kowt between about 2007, 2008 and 2010. And then with the drawdown and withdrawal from Uruzgan province and Tarin Kowt, we've been sending people up till this year, so 2012 to 2014, to the larger hospital, what's called a Role 3 hospital in Kandahar. The vast majority of clinicians, doctors, nurses, allied health professionals that we've sent to those deployments have been reservists. Certainly not all of them. Our regulars, enormous contribution as well, but at the specialist medical end, almost all of them have been reservists, and I guess there was some concern because we hadn't deployed such a number of people over such a prolonged period of time. In particular, as those deployments went for 4 or 5 months, some of them. Maybe the reservists wouldn't be able to generate that capability, and in fact the reverse was true. There was always more than enough volunteers to staff those positions. And I've done that myself, but knowing people who've done that, I think universally people have found that experience very positive. Sometimes with a reasonable impact on their civilian practice, if they had a private practice in particular. But I don't know anyone who regrets having done that. And what's more, I don't know anyone who wouldn't go again immediately, given the chance.
Can you talk to us a little bit about some of the research you're involved in, particularly frozen platelets, which Admiral Walker was very keen to tell me about. Can you tell me a little bit more about that?
Yeah, so my background before coming to this job was as a clinical trialist. I've done my postdoctoral research fellowship in clinical trials and had been happily doing general critical care clinical trials before coming to this job. But with a mandated trauma focus, the clinical trials work that I've been doing in the last 3 years has been very much focused on blood resuscitation and the provision of blood products in austere environments. So there's a few projects there. One, we're working with the National Trauma Research Institute and a variety of civilian ambulance services around Australia to look at the pre-hospital administration of tranexamic acid as a drug that we think might reduce bleeding and improve mortality in trauma. Clearly of benefit to the civilian community if that's the case.
What's the mechanism for it?
The tranexamic acid's a lysine analogue, so it's a very simple drug. It's structured not too dissimilar to a simple amino acid. And I guess to cut a long story short, it binds to an enzyme in the fibrinolytic pathway and switches that pathway off, or at least inhibits it, competitively inhibits it. So it doesn't promote the formation of blood clot, but reduces the speed with which natural fibrinolysis, or potentially what we think is pathological fibrinolysis in trauma, dissolves a clot and therefore maintains hemostasis for longer. There's a very persuasive 20,000 patient randomised controlled trial, the CRASH-2 trial, which showed benefit, showed mortality reduced from 16 to 14.5% with the hospital administration of tranexamic acid. But I guess there's a number of, you might say, concerns about the applicability of that study to a developed world trauma system. It was done mainly in the developing world. And what's more, it was a trial of the hospital administration of that drug. And amongst other things, it demonstrated that the earlier you give the drug, the better, but it's not at all clear whether we are able to give the drug to the right people in the right mechanism, right manner, pre-hospital. So our question in the study is does the CRASH-2 trial apply to a developed world trauma system when it's given as early as can be done in that trauma system,
by paramedics
on the roadside. So that's one study. Another study we're involved in, or at least I'm a chief investigator in partnership with the Australian New Zealand Intensive Care Research Centre at Monash University, is the transfuse study. So we're randomising critically ill patients to the newest bag of red cells in the hospital if they need a red cell transfusion, or standard care, which is to give the oldest bag of red cells in the hospital, obviously prior to their expiry in 42 days. But there's an inventory management mechanism, as you would imagine. If you hypothesise that the age of red cells doesn't have an impact on clinical outcome, you would give the oldest blood, because that way you preserve
more efficient
supply, more efficient. But there are animal studies and I guess some biological rationale that says that there are some people, potentially critically ill patients, potentially immunosuppressed patients, potentially trauma patients, although this study doesn't largely include trauma patients, who might derive some benefit from having the freshest available blood. And for example, there's an American military clinical practice guideline that mandates trauma patients be given the freshest available blood in the hospital, which is an easy thing to say until you think about the implications of that for everybody else who gets blood. Because if you're going to give preference to some people, then other people are going to lose out. And it's not at all clear who are the people who stand to lose the most and gain the most in that sort of equation. So in any case, Transfuse is a 5,000 patient study, civilian intensive care units around the country, where hopefully, at least for critical illness, we'll understand whether age of blood makes a difference.
Okay.
But lots of potential for asking that question of other patient groups. I guess trauma would be, for us anyway, near the top of that list. Yeah. And then the third large clinical trial that I'm involved in related to trauma and blood resuscitation is the cryopreserved platelet study. So cryopreservation, or freezing of platelets, was developed by the US Navy back maybe 40 years ago as a means of providing platelets to their ships on deployment. So platelets conventionally have a shelf life of only 5 days, which means that in civilian practice they're not really available outside large teaching hospitals, where they're given mainly to either haematology patients or cardiac surgical patients. Right. In the military, we have the same problem. We deploy our hospitals to the middle of nowhere, and where they have a high and predictable need for platelets, we're able to provide them by the collection by apheresis from local donors. But where we don't have a high and predictable requirement for platelets for trauma patients, as has been true for us East Timor and so on. So the options there really are to use fresh whole blood from local donors. That seems to be effective, but it comes with some risks to both the donors and the recipients in terms of infectious disease. And although that's definitely still part of our armamentarium, we'd like to have a way of blood banked platelets to be able to give under those conditions. And we think that the cryopreservation of platelets might be the answer. So cryopreservation extends the shelf life from 5 days to 2 years.
Wow.
And we've used, the Australian Defence Force clinicians, including me, have used cryopreserved platelets provided by the Dutch military at the hospital in Tarankout, including to Australian soldiers wounded and treated in that facility. They seem to work. That is to say, they seem to stop bleeding, possibly even more effectively than conventional platelets. So we think that a pilot study of 90 patients will enable us to properly design a definitive study, which I'm imagining would involve around 500 patients in 10 hospitals around the country, which, if we could get it up and funded, I think would be enough evidence for the TGA to register cryopreserved platelets for both civilian and military use. And we'd be the world leaders in that. The Dutch have been enormously helpful in developing the laboratory protocols, but to our knowledge had no intent to run a clinical trial. They've introduced this into military practice and they're perfectly happy with that, so have no imperative to run a clinical trial. And there's a group of haematologists in the United States who we're working with closely who are interested in this technology for haematology patients, and they've designed a clinical trial program that's essentially complementary to ours, looking at people at high risk of bleeding with hematological malignancy. So their study plus our study of people who are actually actively bleeding should, we hope, be more than enough evidence to register the product, if indeed it's effective and comes without too many adverse side effects, which we hypothesise.
So what does Anzac Day mean to you?
Anzac Day to me still, I suppose, revolves around memories of the Anzac Day March.
Yeah.
And my recollection of that's probably, like most Australians, is seeing a lot of elderly men, mainly, certainly our nurses as well, but mainly elderly men, proud to be in each other's company and celebrating, certainly not war, but celebrating their shared experience. And I think feeling very reassured that our community still values that service to the point that they are able to march down the main street of every capital city and country town. And more and more people showing that respect, I know, heartens those people enormously. For me, it's still something for the old diggers.
Yeah.
And I guess I'd now include old diggers as Vietnam veterans as well.
Sure.
I don't know how typical I am of the rest of our Defence Force, and certainly the RSL has been very active in encouraging our more recently returned servicemen and women to march in those parades very proudly, and I know many have very proudly. I guess for me, well, my personal reflection is, yes, I've been to Kandahar and Tarankout, and yes, I've heard the rockets explode, but that experience pales into insignificance of having to get up out of a trench when a whistle was blown, or jump out the back of an aircraft over France, or for that matter, spend 4 weeks on a patrol in Vietnam, not knowing when you were going to step on a mine.
Yeah.
I don't know, I feel as though I personally haven't earned the right to march beside those people.
Well, take it from a civilian. Yeah. Thank you for your time. Thank you for your service.